Hello, my name is Robert Giuliano, and I'm editor-in-chief of the new Anticoagulation Management Clinical Community, which is available on CardioSource. Today, I'm talking with Dr. Mark Chan from the National University Heart Center in Singapore on the topic of novel anticoagulants. Welcome, Dr. Chan.
Thank you, Bob. Thank you for this kind invitation. It's good speaking with you again.
Great. So, why don't we dig right in? Tell us a little bit about the use of oral anticoagulants in Singapore, and if you want to expand beyond that to your region of the world, what can we learn?
Well, think that oral anticoagulation with a vitamin K antagonist, the commonest vitamin K antagonist in use in Asia and in Southeast Asia is still warfarin. I think one of the greatest concerns in this part of the world is bleeding. Bleeding is the commonest adverse drug reaction with warfarin, but it's been shown in a number of population-based studies that Asians might be particularly susceptible to bleeding induced by warfarin. And I believe that you are familiar with the data from Rocket and Aristotle that showed that in patients randomized to warfarin, the East Asian analyses actually showed somewhere in the region of a 25 to 30% increased risk of major bleeding compared to the global population. And in Rely and Rocket, if I recall correctly, somewhere in the region of a 30% increased risk of intracranial bleeding among the East Asian subgroups compared with the rest of the global population. I think these findings have been previously shown as well in population-based studies in 18,000 patient analyses out of the Kaiser Permanente healthcare system, which patients with AF on warfarin, ethnic differences in intracranial hemorrhage to compare, and patients of Asian ethnicity had as much as a 5-fold increased risk in intracranial hemorrhage compared to white patients on warfarin. As such, I think it's quite prevalent in many parts of Asia to be pretty conservative when it comes to warfarin use. I do not have hard figures here, but speaking with many colleagues around Asia, especially East Asian countries like South Korea, Japan, and China, target INR ranges are actually intentionally lowered, and target INRs can be as low as 1.5 to 2.5 in patients who are deemed to be at high bleeding risk, particularly patients who are greater than 70 years of age. Another feature I seem to find about the anticoagulant use in this part of the world is that our TTRs do not, time and therapeutic range seem to be somewhat poorer than other parts of the world. Except for Japan, in which they are really able to keep their patients within target INR range. But if you look at the large trials, many of the East Asian subgroups seem to do poorly in terms of keeping their patients within target INR range. And whether it's due to drug adherence or dietary influence, I really do not know. But that, I think, would be my perspective of the landscape of INR usage in this part of the world. And I think clearly there are many deficiencies in how we use warfarin. There are also many gaps in knowledge. And overall, I think the greatest concern is that there's underuse of warfarin in patients with AF who deserve oral anticoagulation. And another concern is that the TTR range, the time in therapeutic range seems to be lower than other countries.
Very good. Given some of these considerations, the limitations you mentioned with warfarin, the concerns for bleeding, particularly in the East Asian population. What are your thoughts about some of the novel oral anticoagulants that have been developed and now are becoming available for use in practice?
Well, Bob, I think we briefly discussed this when we were in Busan last year in December, and I'm very impressed with some of the subgroup analyses coming out of the large novel oral anticoagulant trials, the subgroup analyses in the East Asian populations. In real life, for example, I think we saw a reduction in major bleeding compared with warfarin in East Asians for both the 110 and 150 milligram dose. But as you recall, in the global population, we only saw a reduction in major bleeding with 110 milligram dose. And with rivaroxaban, we saw somewhere in the region of a fourfold reduction in intracranial hemorrhage in the East Asian analyses by Professor Lawrence Wong. This was significantly greater. There was a clear interaction effect, significantly greater reduction compared to the global population in ROCKET. Similarly, we seem to have seen the same thing with Aristotle. East Asian patients seem to also have less major bleeding, somewhere in the region of a 50% relative risk reduction with apixaban compared with warfarin in East Asians. Whereas in the global population, what we saw was somewhere in the region of a 30% relative risk reduction. So my own take is that the novel oral anticoagulants are really positioned to change clinical practice and change stroke prophylaxis in AF in this part of the world.
Well, thank you so much, Dr. Chan, for your insights regarding the novel anticoagulants. And I'd like to invite you and the rest of our audience today to visit the community frequently for ongoing information about anticoagulation management. This is Robert Giuliano for the CardioSource Clinical Community on Anticoagulation Management.